Hello and welcome to the Clinical Care Options Medical Specialties Podcast. I'm your host, Robin Black. Today's episode features a conversation between Dr. Joseph Kim from Q Synthesis LLC and Natalie Orbach, physician assistant at Feirtag Ramos, PA. They join us today to discuss how to develop patient-centered and tailored treatment plans to improve the quality of obesity care. Listen in to take-home lessons on how to deliver a similar project within your practice or institution. For more information on Dr. Kim and Natalie, along with a link for more QI resources, please visit the show notes for this episode. Now let's get started and hear what the experts have to say about this important topic.
Thank you so much for your willingness to join us for this interview and to share your experiences about providing obesity care. Before we start, briefly tell us about your practice.
So I'm a PA, have been for 25 years. I work in a internal medicine office. It's a private office with one other doctor providing care. We see only adults over the age of 18. Our practice has been around for 35 or 40 years. I've been here for 20 of those years. And so most of our patients are long-term patients who have referred their family and friends to us. So it's a really nice practice.
I know that a few years ago, we had the opportunity to work together on an obesity quality improvement program. And one of the areas of focus was around, tailoring and customizing obesity care for your patients. So what does that mean? Tell us about your process. How do you tailor the obesity care that's offered and provided to your patients?
Well, the first thing is, I always ask patients about their weight. The one thing is I don't typically ask, are you happy with it, as much as how stable is it? And that usually gets the conversation going, certainly with our patients with higher BMIs, where we should be addressing these issues for health reasons. So I try to understand, where they're at thinking about their weight before we even jump into, hey, we need to do something about this. We talk about goals of care in terms of so much not my goals as much as what are their goals. So it's establishing realistic goals. If a patient says to me, I want to be 120 pounds, the question I ask is, well, when was the last time you weighed 120 pounds? So that we can be realistic about setting up our plans for achieving their goals. So I always set goals small, so I personalize it to each patient. I have no rhyme or reason of the way I do it, except it's really very individualized to the patient, the age of the patient, the motivation of the patient. So I really kind of try to keep it as very individualized as I can. So the first thing we always do is talk about what the goals are.
And regarding the way that you bring this topic up, would you find that it's easy to do with new patients? Do you find that you usually wait to establish care before you bring up the topic of obesity care? Like how and when would you say that you normally bring it up with your patient population?
Great question, because I don't know that there's a one way to do it. I think most of my patients that are very well established, we've had these conversations. It's very easy to bring it up. But again, I usually approach the subject of how stable is your weight in terms of over the last few years? And, do we want to make any plans to change that, especially in our obese patients? I met a new patient actually within the last week. That was how I approached it with her. And I said, so, I'm just meeting you today and tell me about the stability of your weight over the last few years. And that got the conversation going right there with no problem, because she said, well, it's not been. I really want to talk about that. I just didn't know when to bring it up to you because we're meeting each other for the first time. So it was just really a very nice in for having that conversation.
It's great to hear. So let's talk about the specific different interventions and modalities of care that go into an obesity care plan, starting with the topic of nutrition. How do you bring this up? How do you address and talk about nutrition with your patients?
So this is another one that's very individualized to each patient, and I do tailor it to each patient. We talk about how they're currently eating, right? So we start there with, well, tell me what you had for breakfast. Tell me what you're planning for dinner or lunch. So we talk about where they're at right now. And if they're skipping meals or they're choosing, fast foods or microwavable meals or what they're doing and how many calories. So we kind of get a sense of that. And then I try to not necessarily change people's habits right away with nutrition, because that's a hard one to do. Because I can't tell you to just now stop going to fast food restaurants if that's your lifestyle. A patient might say to me, well, Natalie, my schedule's so busy. I'm running the kids all over the place. We're stopping in Chick-fil-A. We're going here. We're going there. So I usually say, well, you don't need to get an extra value meal. You can get a kid's meal. So we talk about how can we eat less calories, eat a little bit better with what we're currently able to do. So that's really how I kind of approach that. I really try to individualize it to what they're currently doing. We talk about cutting meals in half. We talk about using smaller plates. We talk about, simple recipes. I'm a big cook. I cook a lot at home. So I talk about some of the simple things I do with my busy schedule. So yeah, I get home. I don't want to be spending 3 hours cooking a meal. So what do I do? And I share some of those things that I do so as to kind of try to offer better healthy habits.
And how about when it comes to either nutrition interventions, referrals, either programs that are available commercially? Like when and how would you say you refer patients to those kinds of resources?
I offer that from the very beginning in terms of if somebody wants to see a dietitian or a nutritionist. We have a program here in Maryland that's called Core Life, which is a program that is often covered by insurance. So it is a really nice resource. And patients go and they meet with the dietitians, nutritionist, and work on calorie counting and making better meal plans. So I do actually offer that from the very beginning as an option for patients if they feel like they're struggling with, balancing the meals. And I have a lot of also literature types of things on nutrition that I give to patients that make it really easy, where sometimes simple is better, because when we make it too complicated, no one has time for that. So I try to keep it simple. I show the divided plate with, a small portion of protein, small portion of starches, and the larger vegetables. And we talk about what all those things are.
What's been your experience when it comes to patients who have tried some of the commercial, either meal replacement plans or some of the commercial dieting plans? And does that come up in your conversations?
I have encouraged some of those programs when patients have used them before and been successful with them. I'm going to tell you, it's not my go-to in terms of recommending because they're expensive. I have a patient who's using that currently and being very successful with it, but she's done it before and it works for her. I do recommend some of these box meals that get delivered to people's homes, because I tell them it makes it really easy because you don't have to go shopping for anything. You don't have to think about it. The directions are all there on a little card, and they're very portioned out meals. So I do talk about those products sometimes if somebody really says, I don't know how to cook, I don't know what to do, but I want to eat healthier. So I have encouraged some of those programs. But again, it's these things, they're not cheap programs to encourage people to do. So I'm always trying to kind of stay within things that are reasonable for everyone.
Let's now talk about physical activity and getting patients to move more. And how do you address the topic of physical activity with patients as well as, set realistic expectations with them?
I always start with, again, like I do with, nutrition, is where are you at? What are you doing currently? If you are doing nothing, besides going to work every day or taking care of the grandkids or whatever it might be, I usually say, let's give one day. You can give me one day out of the week that you take a walk for 15 minutes. So I start slow, and I usually try to add over the weeks more into their exercise, them exercising. Probably the most popular thing I hear all the time is patients will say, I'm going to join the gym. I'm going to join a gym. I've been thinking about it. And I always kind of say, stop thinking about it. We're not going to do it. Let's think about ways we can just exercise without having to go somewhere else or another expense or another commitment somewhere. So I encourage things like internet subscription that allows them to find a class, whether it's Pilates or yoga or Zumba or a mixed fit or whatever you like, even cycling, or a day at the gym where they can go when they have time. So they're not committed to a monthly expense of something they might not be doing. I encourage, especially for busy people, because they can just say, oh, there's a class in this neighborhood, I'm going to go. And they can find it where, close to work. So I usually start with where they're at, and I try to encourage, at least one day, and then we increase depending on what they're currently doing. Patients who are already actively working out. So I have some patients that are like, I'm going to the gym 3 days a week. I don't see anything happening. I usually say, well, what are you doing in the gym? Tell me what your workout looks like. And then we find modifications. So we talk about if somebody's only doing cardio, then I say, let's add a little weight training in there. And no, you're not going to build big, heavy muscles. We're going to just do a little bit more resistance training. So we talk about some things they can do. I've been known to get on the floor in my office and show them some things to do. And we talk about, easy things that are safe. So that's the other thing is just also patients with limitations in their joints and pain. You want to find things. And so it has to be very tailored to that. So I usually talk about that when I know the patient well. And I say, well, if your knees are bad, we're not going to be doing squats and lunges. You're going to be doing the stationary bike or the recumbent bikes. So we find things. And so that's kind of how it is. It's very individualized because we have a good conversation about what they're doing. Simple things that I tell patients they can do in everyday life that they don't realize sometimes is I say, park your car at the end of my parking lot. I want you to walk from that car all the way up to the office, and take the first flight of stairs and then get off and take the elevator up to the third floor for me. So what you're doing is getting a few more steps in, a little bit more activity than what you may have done at all during the day. So it's just also finding how I can build it into their everyday life.
Yeah, changes in the lifestyle and these incremental improvements, obviously. There have been a number of patients who might say, for example, well, the more I exercise or move, the hungrier I get, I eat more. Do you find patients sort of bringing that up and saying, like, this is an issue for me, and so what can I do about it?
I do. So I have a lot of patients that'll say, yeah, when I'm exercising, of course, then I am hungrier. We talk about how many calories they're eating on that average day, and then how much we need to add in because what is their exercise regimens like? So if they're really doing a lot of exercise, I want to make sure that they're getting the right amount of calories. So we talk about their calorie counts and we do it roughly. I promise, most people don't want to sit there trying to calculate their calories every day because it becomes a full-time job trying to calculate these things. But we get rough estimates about what people are doing based on what they're logging or they're telling me they're eating. And what I've done is we either adjust that so that they're less hungry. But the other thing I do is I encourage protein snacks or bars or meals, even simple things like I say, apple and peanut butter or peanut butter crackers, things like that, or a peanut butter sandwich after you work out because, just for the protein to heal the muscles, but also to kind of give them a little bit of fullness. So we just talk about that and increasing proteins if they're really working out a lot more because it takes a lot longer to burn those. So people stay full more.
How about other interventions, whether it's evaluation for surgery or addressing maybe some mental health concerns? Like, how do you incorporate those conversations as well as appropriate referrals if they're warranted?
So I've referred a lot of people for surgical intervention through the years and usually it's a conversation we have when we've been really working hard and with close follow-up and we've done all the things we've talked about and the patient's really committed to a program, but we're not getting the results they're necessarily looking or they're finding themselves just really struggling, it does come up as an option. And, I have a few programs in the area that I refer to that I think are very good programs. And a lot of times I might encourage a patient to go, I say, just go meet them. Let's hear what it's all about because some of these programs have 3 to 6 months that you have to follow more regimented program, dietary restrictions, and they end up starting to lose weight with some of these other modalities that these programs offer. So many of them might get through these programs and not even decide to do surgery. And I always tell them, you're not committed if you do the program. So it's okay. We can just get some information. I have some patients that come in the door and the first thing they want to do is talk about going for, some kind of bariatric surgery. And I'm open to it because, that's their goal. So we talk about, other things they have tried because usually we need to have tried and failed other means of losing weight in order to support their decision to do a surgical procedure. Now, in terms of mental health, so I think mental health plays a huge role in some of our patients with obesity. Certainly if they're, eating for stress or that's their go-to for comfort, whatever it might be, we do talk about it. But that's usually in the conversation when we're talking about what's going on with their eating habits. And patients are pretty forthcoming and they'll say, well, I've just been really stressed out, and that's what's been going on. So I'm definitely looking for the cookies and the ice creams, or I'm, definitely like my fast food restaurants because it just provides me a little bit of makes me feel better. And when I hear those kinds of things, that's when I know we might need to talk with a therapist just to kind of sort that out.
When it comes to referring patients for mental health professionals, to different mental health professionals, do you find that it's relatively easy to allow them to make those appointments and get access, or is it more that they need like a support group? How would you say it's been getting them to see mental health if they need it or to get other mental health needs met?
So I think depending on how I get, I guess, which way I direct them is usually kind of what's going on. So if I have a very situational type of problem that's kind of leading to us kind of being able to stick with a program of weight loss and they're struggling, a lot of times I will have the patients call their EAPs at work if they have them available, because I think that's easier access. Plus, it doesn't create a financial burden on them because these are free access to patients. Other times I refer them out to, we have some groups that we work with and getting whatever mental health services they need. I usually start with therapists as opposed to just kind of referring out to a psychiatrist, because it's, of course, some of the psychiatric medications, when we begin to use them, they are not as helpful when people are losing weight. So oftentimes it really is very dependent on why I'm sending them for mental health services. So I have a lot of resources.
Let's talk now about medications. I'm sure some of your patients come in asking for medications. So, what's it been like for you to talk with patients about the role of anti-obesity medications, as well as helping them get access to these?
This is a great topic, and one of my favorites, actually, because it is a conversation I probably have at least once a day, maybe more than that. But it's a conversation I have a lot because patients are all coming in asking for them by name, certainly by any name that they're familiar with the GLP-1 inhibitors, as well as some of the others that are out there, the phentermine, topiramate combinations. So this is a conversation I have very early on when we're talking about our goals of weight loss. So typically we talk about nutrition, we talk about exercise, but then we do talk about the medications that are available. Some patients come in right as their visit and they say, my friend is on this and this is what I'm thinking. So we talk about the medications, we talk about all the options. So I talk about the injectables as well as all the orals available. We talk about what's going to be the best for that patient, because not every patient can tolerate all of these things. And we talk about dosing regimens of them. I am very, very familiar with all of them and is very, very familiar with all of the insurance companies in our area that cover them, and also with all of the extra programs that are available for patients to get access. So I've used a lot of these medications and I have been continuing to use them and getting patients access to them by just being creative about what's available. So there's, a lot of coupon programs, there's these direct cash programs. And again, it's very tailored to the patient. So if I have a patient that is better suited with phentermine and a little topiramate, then I'll do that, because maybe they want to lose 10 pounds, 15 pounds because the class reunion's coming up. So then we know that we can achieve those goals. But if I have, most of my patients, the injectable drugs, the GLP-1 inhibitors have definitely been the very popular medications. And they are definitely expensive drugs. But again, the companies that make these drugs have offered incredible cash saving programs to make them way more available and affordable. One comment I'll make, though, because there are a lot of these compounded versions of these medications available in our area. And, that's always a question that comes to me from patients about whether or not I feel they're safe and is it an option for them. And I'm a bit discouraging of it because I don't know what this compounded version is. So I'm usually trying to be a little more creative about how we can get the actual medications.
Yeah, it sounds like, with your patient population and just being really familiar with insurance coverage, it's extremely helpful just in terms of even knowing how to guide the conversation. In terms of the work that it takes to fill out things like the prior authorization forms or even submitting for some of these other assistance programs, is that work that you do yourself? Do you have other people within the group who assists with that? Like, what is your process?
I do it all myself. Our medical assistants in our office do not do prior authorizations. Prior authorizations for these medications are very simple. They take but minutes. They really ask the standard questions of the things that we're already doing: comprehensive weight management programs, exercise. They're asking about BMI. They're asking about comorbid conditions. And this is just a very quick click, click, click through the boxes. You show proof of the BMI through the office note. And most of these insurance companies give an approval almost within minutes. But again, I'm very familiar with which ones do approve it. Now, they all require prior authorization. So anytime I write this drug, I'm getting a prior authorization, and I already know that ahead of time. And even using the direct cash programs that we've been able to do, the patient, assistance programs, again, very simple to use. It's done through our electronic record. We just send it off to the pharmacy. You alert the patient that they're going to be notified, and the patient does their part on their end, and it's mailed to their house. So it doesn't take any time at all, at least not for me, because it's very straightforward. And they're all the same. When one comes over, you know exactly what it looks like.
Yeah, no, it sounds like with your electronic version and the way that it's been integrated into your health record, it seems like it's a streamlined process there.
Right.
So as you reflect back and think about this journey of providing obesity care and making improvements in that, using all these different modalities of treatment, what would you say have been some of the biggest challenges you've faced as you've provided obesity care for your patients?
As easy as I made the prior authorization and these available programs, these, the direct cash programs sound, it is easy if people have the coverage and their cost is not prohibitive. But that's probably the biggest challenge, is because on average, these cash programs, it's about $300 to $400 a month for medication. So that's very expensive for a lot of our patients, and it's not affordable. So that's probably one of my biggest hurdles, because then I'm getting real creative about what else we can do and how to do it. One of the other hurdles is making sure that we're just getting our patients back in for follow-up. And I kind of set the standard as soon as I'm seeing the patient and starting these medications. I say, I want to see you every 6 weeks. This is how, I want you in here so we can weigh you. I want to talk about where we're at. I want to make sure we're meeting your goals. Because if you come in 6 weeks or you come in 12 weeks and you're not meeting the goals you were hoping to achieve, then I need to figure out why not. And so we need to make some changes. That's sometimes difficult for patients too, is just being able to keep consistent in coming in. So sometimes that's a little bit of a hurdle.
And as you reflect also and talk to other clinicians about providing obesity care, what advice would you give to others who perhaps haven't really done a lot of obesity care? Maybe they're thinking about it, or they are perhaps developing an obesity care program within their practice. Suggestions or advice for them to consider?
One is familiarizing themselves with the obesity guidelines that are available to us, because I think they're incredibly helpful with good guidance. And even the diabetes care guidelines that come out every year are very good about discussing obesity treatments and availabilities. So I think that the one thing I would say is, don't be afraid to talk about it. Patients want to talk about it for sure. Patients are most of the time motivated. And don't turf everything to someone else. Like if it's talking about nutrition, if it's talking about exercise, we have to be able to start that. So if I just have a patient come in the office and they talk about wanting to lose weight, and my first referral is, well, see the nutritionist. By the time they see a nutritionist, it's a few weeks down the road. We may have missed that window of opportunity to keep that patient moving through their goals and doing the things they want to do. So I oftentimes kind of say, we don't have to know everything about nutrition. I'm no expert, but you and I eat every day. So we know kind of some of the ways to eat that are good choices. We exercise. So it's just giving some guidance, I think, is super important when you have the patient's attention, right? If I got the patient's attention, let me go for it. And sometimes putting together simple handouts. For example, I created a handout that shows the titration, shows when you should be calling me back about it, shows when your follow-up should be, tells you about the side effects, tells you how to deal with them. So it's all the things I said to them, but now I put it in this nice little kind of page for you that just remind you of everything we talked about. I do this with simple things of, measuring things, so, okay, if I tell you that you should eat, your protein should be the size of the palm of your hand. I have a little handout that has those things to remind you. And these are simple things, take minutes for us to do them. But again, it really shows the patient that one is you're committed to their success and I'm invested in it. So it helps.
Those have been great tips and suggestions. As we get ready to wrap up our interview and our conversation here, is there anything else in terms of any thoughts regarding obesity care or just ideas, maybe even for the future of how you would aim to hope to do things differently?
For myself and my practice, I would love to be able to get a support group or something of that nature, but not necessarily support group where we kind of talk, just chatter, but more about where people are offering what they've done, how they've been successful, even bringing in speakers to talk about exercise and nutrition and being able to do more of that. So it's one of the things I kind of want to do. I just need to be able to put it together. Other things that I have done personally with patients that I would like to probably find some way to do it at a bigger scale is, sending, those affirmative text messages saying, or just checking in. So I'd like to be able to do more of that sometimes, just making sure. But time is a lot of times our problem is just having enough time to do all these things. And the other thing is just really, I wish we could get more coverage for these things and more consistent coverage and affordability for these drugs. Even though I feel like they're as good as they are right now, I think they could be better. And it would just give people more access.
Thank you, Dr. Kim and Natalie, and many thanks to you, our listeners, for joining us. As a reminder, to view more QI resources, please click on the link in the show notes. And please be sure to check back regularly for more episodes on important medical specialties topics.